Next, we invite Dr. TEJAL LATHIA for topic General Practitioner's Toolkit for PCOS. Dr. TEJAL is consultant endocrinologist at Fortis, Apollo and Cloud9 Hospitals, Navi Mumbai. She is a co-author of Language Matters for people living with type 2 diabetes in India. Menopause, women's health are few of her many research interests. We have senior gynecologists of Apollo, Dr. Bharati Rathi and Dr. Arun Rathi as chairpersons for this session.
Good outset, I am really thankful to Dr. Anita for bringing all the legendaries in endocrinology society to the city of Akola, because it's really a great pleasure for me to hear from TEJAL LATHIA today, because recently I came across one of the very good publication which I read from Dr. TEJAL LATHIA and Dr. Joshi et al. In the International Journal of Endocrinology and Metabolism. It was on PCOS, and where she labeled it PCOS as a thief of womanhood. And true, ma'am, it's really a thief of womanhood, because it doesn't only affect the cosmetic part or the metabolic part of the women aspect, but also the fertility and the psychosocial part moreover. And therefore, to talk on this, we have none other than a great, actually an author I can say, or a publisher, Dr. TEJAL LATHIA. Let's listen from her.
Thank you, ma'am. Can I start?
Yes.
Go ahead.
So, good afternoon, everyone. And before I start, I want to say, Dr. Shella, thank you so much for setting the stage, because the first 3 lectures were very medical, and I thought that my talk is not going to be very well received, because my talk is not very medical. But she broke the ice and it's made the way easier for me. I'm extremely grateful to Dr. Anita Khandelwal and the entire team, the IMA, as well as the Maharashtra ESI for this kind invitation. I have a couple of MBBS classmates who I'll have the opportunity to meet today because of this invitation. Before I start, I just wanted to have a lighter moment. So this is called the Ebbinghaus forgetting curve. And what this curve shows is that if I tell you 10 words right now, within 1 hour, you will probably remember only 4 of them. And if I asked you after 1 day, then you will probably remember just 2 words. So the moral of the story being that I will make only 3 points, hoping that you will remember at least one of those points if I ask you after 1 day. So this is the point that I want to make for my entire presentation. This is pretty much my agenda as well as my take-home message. The first message is that in adolescence, it's very easy to label young girls as having polycystic ovary syndrome, and as doctors, we are very uncomfortable with not making a diagnosis, and that is why we rush to make the diagnosis of PCOS many times in adolescence. And I'll tell you some data and some clarification on that. The second is that there is no one single treatment regimen for polycystic ovary syndrome, and depending upon the phenotype of the patient, the treatment may vary from no treatment, only lifestyle modifications, to hormonal pills, to laser, and a whole gamut of treatment. So understanding the phenotype of the PCOS is important to decide the treatment. The third point that I'm going to talk about, which I'm very glad that Dr. Shella introduced in the previous talk, is the emotional well-being of women with PCOS. And as Dr. Bharati Rathi was saying, that is something which for the longest time has been completely ignored in PCOS, and now is taking center stage the world over. So adolescent PCOS, to label or not to label? So imagine there's a 14-year-old girl, and none of these are true cases, so please don't ask me any details about the patient, but they're representative examples of what I'm trying to explain. So if there's a 14-year-old girl who's just had a menarche maybe 1.5 years ago, she has acne, which is mild, and she has oligomenorrhea. The cycle is roughly 45 days. She's now in 9th standard, and therefore she's recently gained weight because she goes to school, she goes to classes, and there's no physical activity. She was advised an ultrasound, and all that was written on the ultrasound was that this has a polycystic appearance, and the ovarian volume was measured, which was roughly about 7 or 8 ml. Hormonal investigations were done, And they're very expensive hormonal investigations, and there's this PCOS profile which is done in Bombay, which costs about 10,000 rupees. But it was done and everything was normal. There was no hyperthyroidism, no hyperprolactinemia, the testosterone levels were normal. This young girl was diagnosed with polycystic ovary syndrome. She was given metformin. She was advised lifestyle modifications. And a 14-year-old girl was told about the risk of diabetes and the risk of infertility in future. Now these are the diagnostic criteria for polycystic ovary syndrome, and if you look at the end, these are the diagnostic criteria for adolescents. So they remain the same, which is oligomenorrhea, oligoanovulation, hyperandrogenism, and polycystic ovarian morphology. But the difference is that in adolescents, if you want to make the diagnosis, all three of the criteria need to be present in order to make the diagnosis. The reason I'm making this point is because most commonly what you have is young girls with irregular periods, and ultrasound is done, which is not done very well, and somebody comments that this is a polycystic ovarian morphology, and the girl is labeled as PCOS, is given a long lecture on lifestyle modifications, obesity, and infertility. When you use these criteria to diagnose PCOS in adolescents, there are three important parts that we need to remember. That only acne does not serve as hyperandrogenism. It has to be progressive hirsutism or a biochemical documentation of raised testosterone levels. You cannot make the diagnosis of PCOS within 2 years of menarche. So if the girl has just got her periods about 2 years ago, it's not correct to make the diagnosis of PCOS yet. And the USG is done properly, and ideally a transvaginal ultrasound, which most of the time in our country is not done because young girls are not sexually active, and it's a transabdominal ultrasound which doesn't have a great resolution. But if a transvaginal ultrasound is done with a transducer which is more than 8 megahertz, then the USG should show more than 12 follicles, 2 to 9 millimeters, plus an ovarian volume of more than 10 ml. The USG criteria are in a state of flux, and we will not discuss and go into the details, but overall this is what is expected. The Endocrine Society for Adult Endocrinology says that ultrasound should not be used to diagnose PCOS less than 8 years post-menarche. So most of the time in young 15-year-olds, 16-year-olds, simply looking at the ultrasound and then labeling girls as PCOS is something that we need to reconsider in practice. And I'm not preaching to you. I've made the same mistake, and I've done it many times myself. So if you go back, this girl is less than 2 years post-menarche. She has acne but no progressive hirsutism. There's a polycystic appearance of the ovaries, but the ovarian volume is less than 10 ml. And as I just said, ultrasound really shouldn't be considered as a diagnostic criteria in girls who are less than 8 years post-menarche. So is this really PCOS? Does it need her to be treated with metformin? And do we really need to tell a young 14-year-old girl that she could have diabetes in future, and her parents need to be told that she will have infertility? So this is what we could do. If there is all three classic symptoms, hyperandrogenism, chronic anovulation, as well as the polycystic ovarian morphology, which fulfills the criteria, you could probably diagnose PCOS more than 2 years post-menarche in adolescents. However, there is a possibility that we could label her as probable PCOS, at risk for PCOS, and we could leave the diagnosis open and open to reassessment a few years down the line. Even if a girl is not treated for PCOS at age 14, it's not going to cause great harm. So we could possibly consider probable PCOS in somebody who has hyperandrogenism, chronic anovulation only. We could say that PCOS diagnosis is not possible during adolescence if there is only polycystic ovaries with hyperandrogenism, or there is chronic anovulation with polycystic ovaries. I don't need you to remember any of this confusing terminology. The only thing I need you to remember is more than 2 years post-menarche. If there is progressive hirsutism, there is oligomenorrhea, the cycle length is more than say 45 days, and there is a classic PCOS morphology which fulfills the criteria, you could label PCOS. But in most other girls, if you're not sure, then instead of labeling the girl, you could just put it down as at risk for PCOS or possible PCOS or probable PCOS and leave it there and open to reassessment. So this is the range of possibilities. in a girl where you're considering PCOS in adolescence. Now, why am I so vehement about this and why am I keeping on repeating this again and again and again? The reason is because we want to avoid misdiagnosis or overdiagnosis. You want to avoid unnecessary and inappropriate treatment. We want to avoid unnecessary fear and anxiety, and we want to avoid parent-child conflict, which is just what Dr. Kothari and Dr. Shella were discussing. That a lot of time, the parents immediately start telling the child, you are overweight, you eat junk food, and this is why you have PCOS. Remember, this is a young 13, 14-year-old girl who is not even emotionally mature, is going through her menopausal transition, and really is not in a position to handle this kind of stress. The second point I wanted to make is that there is no fixed prescription for PCOS, and it has to be a phenotype-specific treatment. So you need to look at the patient, you need to understand what their concern is, and you need to look at the medical aspect of it, and together, in partnership with your patient, you need to decide what is the treatment that they want. So in adults with PCOS, we know that 2 out of 3 criteria is sufficient for the diagnosis. Based on this, we can have 4 different phenotypes of PCOS. They're called as ABCD. Again, I don't want you to remember what the different phenotypes mean, but what I would like you to understand is that depending upon the combination of the criteria that they have, the manifestation of PCOS may differ. So for example, if there is only anovulation and polycystic ovarian morphology, then infertility is the main issue that most of these women have, and they're less likely to have metabolic disorders, less likely to have hirsutism. On the other hand, if there is hyperandrogenism and anovulation, or hyperandrogenism and a PCO morphology in ultrasonography, then hirsutism and metabolic disorders are more likely. So again, trying to understand what is the particular combination of criteria and then deciding the treatment is a good idea. Again, this is a representative example. There are a lot of senior and endocrinologists, other colleagues here, and I'm not saying that what I'm recommending is the right way to treat PCOS. What I'm trying to illustrate is that you need to think about the treatment before you give it. If you're not sure, you could reach out to somebody else. If you're a gynecologist, maybe you reach out to your endocrinologist. If you're a dermatologist, you reach out to your endocrinologist. You discuss the possibilities and then finally decide the treatment. So suppose there's a 21-year-old girl, we won't argue, she has definitely PCOS, and her main complaints are delayed menses. She gets periods once every 3 months. Occasionally when she gets the period after a very long time, she has heavy bleeding, and she has very mild hirsutism. Normally if a girl comes with excessive facial hair, unless they complain about it, I always ask them that how is the hair affecting you? And you will be very surprised, there are a lot of young girls who don't care about their hair at all. They don't want any treatment for it, and it's probably the mother who is more worried about it. And there are some girls, even with very little facial hair, it has a huge impact on their mental well-being. So you need to look at what is the impact of the excessive facial hair on the person by asking a direct question and then deciding whether you need to treat it or not and what is the intensity of treatment. Her USG shows ovarian volume more than 10 ml and she has difficulty in losing weight. Now what is the treatment that you would offer this girl? So if there is predominant oligomenorrhea, there is no severe hyperandrogenism, or if there is a little bit of facial hair but the girl is not concerned about it, then simply giving progesterone withdrawal bleed on a cyclic basis is often more than enough to take care of the problem. And lifestyle modification, of course, we would offer along with this. If contraception is needed, then a cyclic estrogen progesterone can be advised. Now, I don't know what the situation is in Akola, but I just had a young girlfriend, boyfriend come to my clinic the day before I left, which was Friday, and they were sexually active, and she had PCOS, and though she had only predominant oligomenorrhea, I discussed it with her, and she would have liked contraception, which is why we put her on hormonal pills. So also asking about sexual activity is extremely important. Again, I don't know what the situation is in Akola, but in Bombay there are a lot of young couples who are sexually active, and offering contraception is a good option if they desire. Now suppose I change the symptoms slightly. She still has oligomenorrhea, but now she has moderate to severe hirsutism. Then in this case, hormonal pills are a good option because they are the best option for treating the hirsutism. So I would probably offer cyclic estrogen progesterone pills. I try not to call them contraceptive pills. Again, words are very important, and when you tell a young 15-year-old girl in front of her parents that we are going to give you contraceptive pills, it has a very big impact on the minds of the parents as well as the child. So I try to use the word hormonal pills. So I would give her hormonal pills with or without aldactone or finasteride. Laser can be considered. Again, in this, you need to ask the patient what she wants. There are some girls who are willing to wait and probably hormonal pills for a few months and then you add on laser. If it's having a huge impact on their mental health, then you need to start the laser as soon as possible. I remember this young girl told me that, one of my friends in college, he's a boy, he came, he rubbed his hand under my chin and he said, "Hey, tujhe to daadi aa rahi hai ladko jaisi." So for her, it was like it really shattered her confidence and her self-esteem. And she was really, she spiraled into depression. So in a person like this, starting the laser early, giving them relief from their hirsutism is extremely important. So it would depend again on the person. You could use local cosmetic measures if they are struggling with acne or alopecia. I just wanted to point out one thing, and it may seem actually, weird that I'm constantly talking about not intervening, but repeatedly harping on lifestyle modification with every single patient with PCOS can often be very counterproductive, and I'll give you an example a little later on. So just to clarify, the lifestyle modifications have a limited impact on the hirsutism. So a lot of times, even if a girl has severe hirsutism or moderate hirsutism, she's sent back saying, "Aap metformin khao, weight kam karo, sab theek ho jayega." Well, that's not going to happen in most of the cases. Now suppose the same girl now has regular periods, she doesn't have oligomenorrhea, she still has moderate to severe hirsutism and she has a normal BMI. Now I purposely put the word normal BMI because what has happened is that reflexly we say lifestyle modifications to every single PCOS girl who walks into our clinic. Now a lot of the girls that I see with PCOS are actually thin, their BMI must be barely about 19 or 20 or 21. So in this case again, lifestyle modifications alone are not going to have a major impact and you do need to treat them. It's a little bit tricky because if she already has regular periods, many of the times the women say or the mothers will say that but her periods are already regular, why are you giving her a hormonal pill which will regularize her periods? So you could try possibly aldactone or finasteride, but the problem is that when you use aldactone alone, it often ends up in polymenorrhea, which can actually make it more difficult for the girl. Of course, laser is always a consideration. Again, there could be a limited role of lifestyle modification in this particular case. So as I said, limited impact of lifestyle modifications on hyperandrogenism. The second thing I wanted to say is most of the girls are told in the adolescent period especially, "Aap weight kam kar lo na, sab kuch theek ho jayega." So I remember this young girl came to me and she said, "You know what, मुझे डॉक्टर ने बोला था वजन कम करो सब ठीक हो जाएगा। मैंने 20 किलो वजन कम किया मैम, मेरा पीरियड अभी भी irregular है." So weight loss may resolve the oligomenorrhea, but it doesn't necessarily mean it will resolve the oligomenorrhea. So we need to be clear about that, but it may not solve the problem. And this is something, the reason why I kept on talking about not harping on lifestyle modifications every single time is because in the past 1 month, I've seen 4 girls with eating disorders. Because ever since they were adolescents, every single time they walked into any doctor's clinic, be it a dermatologist, be it a gynecologist, be it an endocrinologist, be it the family doctor, everybody told them lose weight. So all 3 of them have developed eating disorders now. All three of them are in therapy now and are struggling with anxiety. So we have to be mindful of what we're speaking. We need to find out whether they're already doing lifestyle modifications, and we need to do it in a better way. The lifestyle specific treatment, I have just one slide on this, that the treatment of PCOS evolves as the girl transitions through her adolescence, through her married years, and as well as in the later years. So often in the adolescence, regularity of periods is the main concern. In the 20s, it is the hyperandrogenism, the cosmetic appearance, they're going to be married, that is the predominant concern. And obviously once they're married, a lot of times fertility is the major concern. What definitely not to do in PCOS? Please don't tell young adolescent girls that they will have infertility when they grow up. Believe me, if you have a daughter who's 14 and the doctor tells her that she's going to be infertile, it's not something that's very pleasant and which you would like for your daughter. blame or shame women for failure to lose weight. And I don't need to say anything about this because, as Dr. Shaila said, obesity is a chronic medical condition. It needs to be treated like any other, and it's time that we stop people from blaming people for their weight. And the last, believe me, I'm not making this up. I remember this girl told me she was 21. She went to the senior most dermatologist in Navi Mumbai, and he told her at 21, "Kuch bhi karo, ab bhi shaadi kar lo, nahi to bachcha nahi ho." Right? So she said, and you know what her answer was to doctor, मैं क्या करूँ, सड़क पे जाके जो पहला लड़का मिले उससे शादी कर लूँ. And this is all doctors have spoken, and I'm not making it up, I promise. So the most important part of my talk, the part which is closest to my heart, is the emotional well-being of women with PCOS, which is something that we almost never consider. So a part of the paper that we wrote, which Dr. Bharti was talking about, is the biopsychosocial approach to PCOS, where we must consider the mental health, we must consider depression, anxiety, psychosocial dysfunction, eating disorders, which are very common in PCOS. We have to think about self-image, self-esteem, and the family and social support that the girls have. And of course, all of this has an impact on quality of life. And finally, in the latest update on PCOS in the Endocrine Society, the US Endocrine Society, in our premier journal, which is Journal of Clinical Endocrinology and Metabolism, have included behavioral and emotional issues in PCOS, and also for the first time have mentioned the quality of life in girls with PCOS. Because as ma'am again said, PCOS can be the thief of womanhood, because there's something which chases them right from the time that they're adolescent all the way to menopause. I'm not going to go into any of the details of any of these studies that we've done, but the next 3 slides are part of the work that we did together to investigate emotional well-being in PCOS. So we started with a systematic review and meta-analysis about the psychosexual well-being of people with PCOS, and we found that PCOS women experience a greater degree of sexual dysfunction, a lot of body image concerns, and it is something that we need to think about. This is a study which is called the Blue Morpho study. This was for self-reported PCOS. So any girl who thought that she had PCOS had been told, means not necessarily diagnosed by an endocrinologist. So there were about 758 women, and this is the prevalence of anxiety, depression, body dysmorphia, weight stigma, and psychosexual ill-being that girls with PCOS experienced. Now this was a study which was in collaboration with the University of Birmingham. So the data on the left is from the UK, and the data on the third column is from India. So girls in India have more anxiety, more depression, less body dysmorphia, do experience weight stigma, but less than that in the UK, and also experience psychosexual ill-being, but less than that in the UK. So there is a major problem, and we're not just making up that psychosocial well-being is important, but we have the proof that there is a huge prevalence of anxiety and depression and mental ill health in women with PCOS. This was a study which is called the PCOS Seva study. Now this was a clinic study which we did, and I forgot to say that Dr. Shaila Sheikh's daughter was also part of our study, where this was an endocrinologist diagnosed PCOS. So now the PCOS diagnosis is more firm, and yet 50% of women had anxiety, 11% had depression, 25% had body dysmorphia, higher scores on psychosexual well-being. So higher score means that they have problems, and higher scores for weight stigma as well. So the reason I'm throwing all these figures at you is because doctors always want proof. Unless I show you proof, you'll say, अरे वो ना वो फीमेल एंडोक्रिनोलॉजिस्ट है, वो ऐसे ही सब बोलते रहते हैं, इतना सब बोलने के लिए, देखने के लिए किसके पास टाइम है? But the truth is that women are suffering, and we need to be cognizant about it. Now this last sentence, I don't know if it will be well accepted, but this is a paper that we published on systematic review of lived experiences of people with PCOS. And one of the things that came out of the study is that adults and adolescents with PCOS are dissatisfied with the care they receive. They receive fragmented care, they do not receive empathetic and compassionate care. The journey to the diagnosis of PCOS is very long, it's confused. One doctor says you have PCOS, one doctor says you don't have PCOS. So I think that as doctors we need to realize that there's a lot more to PCOS, and we need to work in collaboration with each other to treat PCOS better. What could you do? Simply ask girls how they're coping with the PCOS. How does the facial hair make you feel? Are you experiencing any bullying? Do you feel anxious? Do you have low mood? Are you able to sleep well? You need to ask whether she's getting support from her family and friends. One very important thing that I learned, and I'm sure Anurag will remember this, that when we gave our DM final exam, Dr. A.C. Amini, who passed away, was an amazing endocrinologist. And all through our exam, I don't know if Anurag said it, but I kept saying, I will counsel my patients. I will counsel my patients. And Dr. Amini, after the entire exam, told me, she passed me, but she said, you know what, Dr. Tejal, you're not trained to counsel people. You're a doctor, and you are trained to give medical treatment. You can give education and information, you can share information with your patient, but you can't counsel your patients. So if your patient has an eating disorder, has severe anxiety, has severe body dysmorphia, has weight stigma, then it's a good idea to take the help of a counselor or a psychologist. And in many cases, some women also require a psychiatrist, especially if the eating disorder is pretty bad. So I have a girl who had PCOS with type 1 diabetes, and her weight went from 60 kilos to 30 kilos, and she had to be admitted in emergency at King's College London, where she had gone to visit her brother because of the dramatic weight loss she had, because she had developed anorexia nervosa. So though she was type 1 diabetes, she had PCOS, she was overweight, and every single doctor used to tell her to lose weight, and she ended up in anorexia nervosa. She spent 3 months in the hospital. So again, I'm leaving you with only 3 messages, which I hope you'll remember at least one of them till tomorrow. Don't rush to label young girls or young adolescents as PCOS. If you're not sure, write down probable PCOS, at risk for PCOS, tell them come back in 2 years, we'll see what happens. And if the oligomenorrhea is there are long gaps, you could just give progesterone withdrawal bleeding. When the patient is sitting in front of you, really look up from the paper, leave your pen aside and see the patient. What are her concerns? What are the obvious medical issues? And please treat them according to the phenotype that they have. Consider and inquire about emotional well-being. First of all, consider that girls with PCOS have emotional ill health, and then ask about it. Don't wait for the patient to volunteer the information. Many girls are very well adjusted with their PCOS. They really don't have any problems, and you can leave them alone. But there are girls who need help, and it's our duty to offer them help. So I think this summarizes Dr. Sheila and my talk, that words have energy and power and ability. They have the ability to help, to heal, but also to hinder, to hurt, to harm, to humiliate, which I'm sure all of us have done at one time or the other to obese people, and also to humble. Thank you.
Thank you, madam, for excellent coverage on this diversity and PCOS. Basically, what I like most is not the drugs and diseases only, but your social and mental health coverage in this lecture. Thank you. Now, any question from the audience on this issue?
I wanted to maybe know your comment about overall final prescriptions, and do you feel that we are over-prescribing metformin and under-prescribing OC pills? Maybe that acceptability is not even poor amongst patients but also amongst doctors.
So yes, I absolutely agree with you that for the longest time, and Amay will agree with me, Dr. Bhagwat is here, that when we were training in endocrinology for PCOS, at that time we did write metformin for every single girl who came into the clinic, because that was what the recommendation was at the time. But the latest recommendation from the Endocrine Society does say that metformin should be used judicially. We mainly use it for girls who have dysglycemia. So if there is pre-diabetes, there's diabetes, there's glucose intolerance, that is the time that we use metformin most commonly. In very rare cases, if a patient doesn't tolerate progesterone-only pills in adolescence, then metformin can be used, because sometimes it helps to regularize the periods. But yes, it doesn't have to be part of every single prescription for PCOS. And yes, I completely agree with you that we underutilize hormonal pills. Again, I'm trying very hard not to use the word oral contraceptives, because everybody can Google the word contraceptive and parents are very unhappy when you use that word. But yes, if there is severe hirsutism, no matter how much weight she loses, no matter how much metformin you give that girl, the hirsutism is not going to go away. And I'm talking about, I had a girl just this week in the clinic who has an entire beard. And telling this girl that you take metformin and do lifestyle modifications is not on. She will require hormonal treatment. She will require laser, and that's the treatment that you have to give. I know that there is a huge reservation among doctors because of the risks of hormonal pills. And if the girl is less than 40 years of age, she doesn't have uncontrolled hypertension, she does not have uncontrolled diabetes or any complications of diabetes, she is not a smoker, then most of the time it's safe to give the hormonal medicines. Just ask for a brief history if there's any history of deep vein thrombosis in the family, and most of the time there won't be. And choose a estrogen-progesterone combination which is low risk for deep vein thrombosis as well as has some amount of anti-androgenic effect. And usually most of the time the medicines work very well. It also balances the hormone, they help to lose weight, and the hirsutism does improve to a great extent. Yes, it's very difficult to convince the patients, but I think the doctor needs to be convinced first themselves before they can offer anybody else the treatment. Thanks so much.
Thank you for the insightful session, ma'am. I request the faculty and chairpersons to please come up for that stage. I would like to extend special gratitude to Dr. Vaisar sir, who agreed at the last moment to be the chairperson. Thank you, sir.
I request Dr. Shivaji President sir and Dr. Mandhani to please come forward and felicitate the chairperson.